Sahil. I am a first year MD cardiology resident here at the Infarcted Institute. Today I will be talking about electrocardiographic localization of infarcted coronary artery in a case of acute ST elevation myocardial infarction.
Just to call it introductory point, તમે MBBS ને MD ક્યાંથી કર્યું?
Sir, I completed my MBBS from Nagrani Institute of Medical Sciences.
Good.
And then I did my MD from Bharatiya Vidyapith Medical College, 2017.
But have you worked as a post-MD consultant or resident anywhere?
For 2.5 years I was working as a consultant.
Okay.
Same Pune.
At Nadia.
Nadia.
Nadia to કઈ જગ્યા?
Sir, my own private, my father.
Your father is a physician?
Yes.
Okay, good.
अच्छा ये नागरानी ये फिजिशियन है क्या ना?
Yes. Dr. Harish Nagrani.
हाँ नडियाद है ना?
Yes.
Good.
तो नडियाद में मेडिकल कॉलेज में है तो?
ધરમશ્રી બોર્ડ એન્ડ થ્રી સાઇઝ. ધરમશ્રી દેસાઈ તો બોર્ડ है.
6 years. 5-6 batches. So starting with the basic anatomy and surfaces of the heart. From the anterior side we can see that the anterior surface of the sternocostal surface is mostly composed of the right ventricle and some part of the left ventricle as seen from the front in anatomical position. Then the right pulmonary surface is mostly composed of the right atrium. From the posterior side and from the inferior side, the inferior surface is mainly composed of the left ventricle and partly the right ventricle. Similarly, the left pulmonary surface is mostly composed of the left ventricle and slightly the left atrium. And the base of the heart is mostly composed of the left atrium and slightly the right atrium. So, the anterior surface is mostly composed of the right ventricle and partly the left ventricle. The base is mostly composed of the left atrium and partly the right atrium. And the inferior surface is mostly composed of the left ventricle and partly the right ventricle. Now, talking about the standard 12-lead ECG. These are the standard limb leads with there are total 10 electrodes and 12 leads. So electrodes are basically a conducting pad that is tied to the body for measuring the electrical activity of the heart, and leads are the graphical representation of the analysis that is done with the help of the leads, with the help of the electrodes. So lead 1, there are 4 electrodes which are placed over the body, 1 each on the right arm, left leg, right arm, right leg, left leg and the left arm, where the right leg electrode serves as the ground electrode. So lead 1 is computed by taking the exploring electrode as the left on the left arm and the base electrode on the right arm. So the lead 1 views the heart from the left side. Similarly, lead 2 is computed taking the base electrode on the right arm and the exploring electrode on the left leg. So the lead 2 views the heart from the inferior side. Similarly, lead 3 also views the heart from the inferior side. Now talking about the augmented limb leads, they are AVR, AVL and AVF. Lead AVR is computed taking the electrode on the right arm as the positive electrode, with the base electrode being the average of the electrodes, potentials of the electrodes composed of the left arm and the left leg. So lead AVR views the heart from the top. So similarly, leads AVL and AVF also are computed as is lead AVR. So as from the image we can see how lead AVL and AVF also view the heart. So these are the standard limb leads that are 4 in number. The next are that are 6 in number, sorry. And next are the standard chest leads. These are composed by placing 6 electrodes on the chest, with the reference electrode being the Wilson's central terminal. Now Wilson center terminal is computed taking the average of the 3 electrodes, that is the ones on the right arm, left arm and the left leg, the sum of which is 0. So the reference electrode is the Wilson center terminal and these 6 chest electrodes make the 6 chest leads. So these leads are placed, lead V1 is placed in the 4th intercostal space just right of the sternum. Similarly, lead V2 is placed on the 4th intercostal space just left of the sternum. Lead V4 is placed in the 5th intercostal space in the mid-clavicular line. Lead V3 is placed exactly between leads V2 and V4. Leads V5 and V6 are placed in the anterior axillary and the mid-axillary line at the same level as V4. So in total, these are 12 standard chest leads that are used to compose a standard 12-lead ECG. Now these are supplementary leads that are used in special scenarios. So as the right side of the heart is not viewed exactly on the standard 12-lead ECG, so leads V3 V4 and V5 are corresponding to the leads on the left hand side are placed on the right hand side to view the right side of the heart. Similarly, to view the posterior of the heart, leads V7, V8 and V9 are used. So leads V7, V8 and V9 are at the same level as leads V4, V5 and V6. In the posterior axillary line is V7, at the angle of the scapula is V8 and the paraspinal region is lead V9. Now coming to the coronary artery anatomy, the coronary arteries right and left arise from the respective aortic sinuses.
For my curiosity, go to previous slide. See, your ECG machine do not provide more than 6 case rates. So how do you take V7, V8 and V9?
So these are supplementary.
Suppose I want to take, then the ECG machine only provides the 6 case rates. How can I take V7,
4, 5, 6 કાઢી અને 7, 8, 9 પર મૂકી દેવાની એટલે છેલ્લી 3 લીડ સીધું એ બતાવશે 4, 5, 6 કાઢી અને 7, 8, 9 પર
અધર પેશન્ટ ને તો પણ લેફ્ટ લેટરલ પોઝિશન માં રાખવું પડશે ને કારણ કે આ નીચે દબાઈ જશે
યસ
હા પોઝિશન ઓફ ધ આ તો મારે ક્યુરિયોસિટી માટે I have not taken this V7, V8, V8, 9 any time. So in that case I will keep the patient on the
Left.
કોઈને આઈડિયા છે ને કોઈ લેવાયો છે 7 8 9 સુધી ગયા છે એટલે
ઓ રોટેટ છે સર પોસ્ટેરિયર એમાં ખાલી લેટર કરીએ ને
પોઝિશન ચેન્જ કરી દો
જે 4, 5, 6 છે ને એ કાઢીને 7, 8, 9 પર મૂકી દેવાનું એટલે છેલ્લી 3 લીડ પોસ્ટેરિયર
પોઝિશન ચેન્જ કરો તો હાર્ટની પોઝિશન કેવી થાય
ના પોસ્ટેરિયર વોલ વિલ રિમેન પોસ્ટેરિયર વોલ ઓન્લી આ હાર્ટની માઇનર પોઝિશન અંદર તમારા થોરેસિકમાં ચેન્જ થશે પણ ઓરિએન્ટેશન ના ચેન્જ થાય લીડ હોય તો that will remain same.
Now coming to the coronary artery anatomy, the right and left coronary arteries arise from the respective aortic sinuses, and upon origin, the right coronary artery begins by giving a branch to the SA node, that is the first branch of the right coronary artery, then continuing in the anterior right atrioventricular sulcus, it continues and gives atrial branches to the right and left atria. That is, these are the second branches. Then the third branch is the acute marginal artery, which supplies the LV free valve. Then further, the right coronary artery takes a wrap and goes into the posterior atrioventricular sulcus and supplies the AV node. That is the fourth branch of the right coronary artery. Then it continues into the posterior interventricular groove and gives the posterior descending artery. That is the fifth branch. So this is the anatomy of the right coronary artery. Similarly, talking about the left coronary artery, upon origin itself, it divides into the left anterior descending and the left circumflex artery. Then this picture is actually not doing justice to what I want to mention, but the first branch is the D here stands for diagonal and S here stands for septal. So the first branch is is branch B1, which supplies the lateral wall of the heart. Then the first septal branch is S1, which supplies the septum, that is the intraventricular septum. Then leads D2 and D3, that is the diagonal 2 and diagonal 3, supply the anterior wall of the heart. So, taking the coronary anatomy and the ECG leads together, the septum, that is the intraventricular septum, is viewed mostly by the lead V1 and partly by the lead V2. So leads V1 and partly V2 can be called the septal leads. Similarly, the anterior and the anterolateral walls are viewed by the leads V3, V4 and V5, V6. The inferior wall is viewed by the leads 2, 3 and AVF. The lateral wall is viewed by leads 1 and AVF. And these are the respective coronary areas of the heart. This is a pictorial representation of the areas of the heart that are supplied by the coronary arteries. So the one in the maroon color is supplied by the left anterior descending artery. The inferior wall is mostly supplied by the right coronary artery. And the one in the orange color is mostly supplied, that is the anterolateral part, is supplied by the left circumflex artery. This is a concept of dominance, that is, dominance is decided upon which artery gives rise to the posterior descending artery. So if the posterior descending artery in the posterior interventricular groove arises from the right coronary circulation, that is the right coronary artery, it is known as right dominant circulation. It is the most common pattern of dominance and seen in 80 to 85% of patients. If the posterior descending artery arises from the left coronary circulation, it is known as a left dominant circulation, which is seen in 10 to 15% of the patients. And in a few patients, we can also get a co-dominant circulation where the posterior descending artery is a combination of arises from both the right and left circulations. So these are the branches of the right coronary artery, as I discussed. After the fourth branch, that is the branch to the AV node, there are terminal two branches. One is the posterior descending artery and one is the posterior basal artery, which supplies 15 to 20% of the left ventricle. So talking about the right coronary occlusion, we can, for the purpose of discussion, we can divide it into a proximal RC occlusion and a distal RC occlusion. Proximal RC occlusion means the occlusion is proximal to the origin of the acute marginal artery, and distal RC occlusion is distal to the origin of the acute marginal artery. So in a right dominant person where the origin of the posterior descending artery is from the right circulation, a proximal RC occlusion before the acute marginal artery's origin will give rise to right ventricular MI, right ventricular free wall MI with inferior wall MI, with or without posterior wall MI, as mostly the posterior wall MI will be present, but the posterior wall can also be supplied by the left circumflex artery, so with or without posterior wall MI. Similarly, in the same person, if there is a distal RC occlusion, it will give rise to inferior wall MI and posterior wall MI. In case of a left dominant person, that is the posterior descending artery arising from the left circulation, a proximal RC occlusion will give rise to only RVMI, and a distal RC occlusion may produce no MI. So now starting with ECGs related to the right coronary circulation and myocardial infarction. So to localize the coronary artery, we have to measure the amount of ST elevation in the inferior leads and the corresponding changes in the chest leads as well. So in this ECG, the ST elevation amount is more in lead 3 than in lead 2. Therefore, the vector is injury vector is directed towards lead 3. So the occlusion is in the right coronary, the patient is right dominant, the occlusion is in the right coronary artery and its branches. Next, as the standard 12-lead ECG does not view the posterior wall, so if there is ST depression such significant ST depression V2, V3 and V4, it can be said that the patient has posterior wall MI as well. Secondly, thirdly, as V1 is the septal lead and there is discordance, that is, as V2, there is no significant ST depression seen in lead V1 as compared to leads V2, V3 and V4. As the right ventricular infarction injury vector will try to pull the ST segment upwards. So there is V1, V2 discordance. So we can conclude that the patient also has RVMI. So in this case, the patient has RC occlusion prior to the origin of the acute marginal artery with or without posterior wall MI. So this is a case of proximal RC occlusion. Now in this ECG, there is significant ST elevation seen in lead 2 more than lead 3. So the injury vector is directed towards lead 2. So this is a case of inferior wall MI with injury vector directed to lead 2. So it is a case of LCX occlusion. So in case of LCX occlusion, if it is producing inferior wall MI, the patient is left dominant and also the patient has posterior wall MI as well. Now, similarly, in this ECG,
So apart from the ST segment, there is another huge difference in the pulse rate of both the ECGs. That can also give rise some
Yes, sir.
indication.
yes, sir. In the first ECG, the patient has sinus bradycardia.
No, it's not. Where is the use? It is not sinus.
There is only bradycardia will detect.
CHP also લાગે છે V2 માં તમે P
In
wave.
V2 we can see one P wave. This is CHP. This is not
CHP, yes.
sinus bradycardia. So any rhythm disturbance is also suggestive RCA involvement rather than LCX involvement.
Right.
And that will you always expect in proximal RCA.
Yes.
Block and bradycardia.
This patient may be hemodynamically highly unstable.
So in this case, we have been provided leads V3R, V4 and V5R in the ST segments in the leads 2 and 3. ST segment in lead 3 is significant than that in lead 2. This is a case of inferior wall MI with RVMI, with or without posterior wall MI. Mostly, this patient does not have. Okay, so in this case, this is a case of inferior wall MI with RVMI, as there is also occlusion in, as there is also elevation in leads V5 and V6. The right coronary artery is going and supplying part of the lateral wall also, which is giving rise to this ST elevation in leads V5 and V6. So this is known as a wraparound RC. In this case, the ST segment, this is not a very classical ECG, but still in this case, ST elevation in lead 2 is more than that in lead 3, along with significant ST depressions in leads V2, V3 and V4, suggesting L6 involvement, that is inferior wall MI with posterior wall. Again, in this case, the ST elevation in lead 3 is much more than in lead 2.
The
With
last ECG was probably true posterior wall rather than inferior.
Yes.
Right? કારણ કે તમે lead 2, lead 3 માં elevation બોલો છો, that looks little questionable from here at least. અને V1 થી લઈને બધામાં જ you can see a very good ST
More of a
difference.
posterior wall. It's a true posterior.
Looks like a true posterior wall MI.
right. Yeah, in this case, again, there is significant ST elevation in lead 3, more than that in lead 2, along with ST depression in leads V2, V3 and V1, V2 discordance, which suggests proximal RC occlusion leading to inferior wall MI, RVMI, and may or may not be posterior wall. Again, in this ECG, ST elevation is more in lead 3 than in lead 2 with V1, V2 discordance. So this is again a case of proximal RC occlusion. Also, this patient has complete heart block, and that is the QRS complexes and P waves are going in their own rate. So this patient may require pacing. Now this is an ECG of a patient, a post PCI ECG.
How it is CHB?
Sir,
Looks like Mobitch 2, એટલે આખી rhythm હોત તો વધારે ખબર પડે, પણ
rhythm shift નથી એમ.
CHB હોય એવી તો possibility pulse rate જોઈને બી નથી લાગતી. લાગે છે ડોક્ટર?
P waves are there actually even in last V6 માં भी જોઈએ ને તો QRS वाला P waves છે. Last complex.
CHP લેબલ કરવા માટે rhythm shift જોઈએ
compulsory.
કે નહીં?
Initially तो P wave clear cut દેખાય છે. That is first degree heart initially. Initial 3-4 waves. પછી થોડા QRS duration વધ્યા છે, RM interval વધ્યા છે, પણ P wave લાગે તો છે વચ્ચે.
It's like 2 months. Grade 2 એવી બ્લોક છે 1 K2, પણ આખી rhythm હોત તો ખબર પડે.
Maybe intermittent CHP હશે. That's why required tissue.
now this is an ECG, a post patient of a patient with inferior wall MI, a post PCI ECG. Post PCI, the patient developed CCF. There on auscultation there was third heart sound. There was no murmur. There is good resolution of the ST segment, and the patient has an ejection fraction of 60% that suggests there is successful reperfusion. So this is a case of papillary muscle rupture leading to secondary MR. You see the corresponding signs and symptoms.
એટલે આ પેપિલરી મસલ રપ્ચર એ તો પછીથી ખબર પડી જશે ને. ઇકો કેવું છે?
Echo diagnosis.
Echo diagnosis છે.
Clinical diagnosis, but not an ECG.
Yes, sir.
Echo diagnosis.
ઇકો ડાયગ્નોસિસ.
Sir, I included that just for
No murmur. So will you expect
એટલે કોઈ
MR in
મરમર
this
નહીં
patient?
એટલે એની અંદર મરમર હોય.
Will you expect MR in this patient? Will you expect then a murmur at least? Pansystolic? How without a murmur?
The early systolic murmur has to be there because it is secondary MR, which is acute MR.
And rupture છે તો કોઈ બીજો સાઉન્ડ નહીં આવે પહેલા?
Yes, sir.
બહુ જલ્દી ડાયગ્નોસિસ પર જમ્પ કરો છો.
એટલે આ આખું ડિફરન્ટ છે પેલું
Yes.
ઇકો ડાયગ્નોસિસ.
We can ignore this.
ઇગ્નોર
Now, in this case, the patient has significant ST elevation in lead 2, more than that in lead 3. Also, there is ST elevation in leads V5, V6, and also some part in lead V1. So this is a case of LCX lesion producing inferior wall MI, of course posterior wall MI, as well as lateral wall. Now, similarly, in this case, again, the patient has significant ST elevation more in lead 2 than in lead 3, along with ST segment depression in leads V2, V3, and ST segment elevation in the lateral leads, that is V5, V6, as well as some ST elevation in leads V1. So this is again a similar ECG of a patient with an LCG. Now, in
પેલા
this-
rhythm કે કઈ છે જો. પછી ST પર આવો. Rhythm shift કેમ નથી?
બધામાં રિધમ સ્ટેજ જોઈએ actually.
Yes. This patient, this is an ECG of a patient with
No meeting. Not recorded.
Not very.
no recorded. Again, here the ST segment in lead 3 is much more elevated than in lead 2. So it is a case of an RC occlusion, and there is V1, V2 discordance. So there is RVMI as well. So this is a case of proximal RC occlusion, and BP may be low because of complete heart block. Of course, for that diagnosis we need a rhythm study.
ના, પણ આ કમ્પ્લીટ હશે કેમ કે લીડ 2 માં જોશો ને તમે તો એમાં તમને 3 P વેવ દેખાય છે. QRS માં એક P છે જો વચ્ચે. લીડ 2. રાઈટ, સો ધીસ ઇઝ કમ્પ્લીટ one. છે QRS માં એક P.
આ જ્યારે પેલા AVF અગાડે તમને દેખાય છે આજે અત્યારે એરો છે ત્યાંથી બધા P સાઉન્ડ દેખાય છે. CHP
Now, coming to the
No,
left.
no, you have not mentioned about posterior leads.
Sir, I spoke about V7, V8 and V9.
Okay.
Now, this is about the left coronary artery. As I mentioned earlier, I spoke about the anatomy. That the left coronary artery immediately divides into the left anterior descending to the left circumflex artery. And V1, the branch V1, that is the first diagonal, supplies the high lateral wall. The first S1 is the septal branch which is directed towards and supplies the septum. Leads D2 branches diagonal 2 and diagonal 3 supply the anterior and the lateral wall respectively. So, according to the ECG leads V2, V3 and V4 can be considered as are considered as the anterior leads. Leads V5 and V6 are the lateral leads. The lateral wall may be supplied by the LED or may be supplied by the LCD. Leads 1 and AVL are called the high lateral leads. Again, that area of the heart can be supplied by the LED or the LCS. Septal leads are leads V1 mostly and also V2, and lead V4 is the apical lead. So here, localization in a case of anterior wall MI is before D1, between D1 and S1, or below S1, that is between S1 or between S1 to D2 or between D2 to D3. So now this is a case of anterior wall MI showing ST elevation significant in the anterior leads and corresponding reciprocal changes in leads 2, 3 and AVF. Here there is ST elevation which is present in leads V2 as well as V2, V3 as well as lead V1. So definitely the lesion is above the septal branch, that is above S1. And in leads 1 and AVL as well there is ST elevation. So the lesion is above the high lateral lead, that is the lesion is above D1. Mostly there is LED, according to the ECG, there is LED occlusion mostly before D1 producing septal, anterior and high lateral canal. Now in this ECG, there is ST elevation in leads V2, V3, V4, lead 1 as well as in lead 2. So, and there is no ST elevation seen in lead V1. So probably this is a case where there is LED occlusion below S1, the ST elevation and with some wrap around, that is the LED is wrapping around and supplying the inferior wall. That's why there is ST elevation in lead 2 as well. The ST elevation in lead 1 can be explained by another lesion present in LCX. Now in this ECG again there is ST elevation seen in leads V1, V2, V3, V4. In leads 1 and AVL there is significant ST depression. So the lesion has to be between D1 and S1, that is above S1, leading to anteroseptal level. Again in this case of an anterior wall MI, there is significant ST elevation leads V2, V3, V4, leads 1 and AVL. Actually, this is labeled as an above D1 lesion, but this is not a classical ECG. Maybe there can be a more on repeated or serial ECGs that we can also get a ST elevation in lead D. In this ECG, there is ST elevation in leads V2, V3, V4, and I discussed this ECG previously, sorry. There is ST elevation in leads 2 as well as in lead 1, but there is no ST elevation in lead V1. So the lesion is below septum, below the septal branch, that is below S1. The septal lead, that is the septal branch. The lesion is between D1 to S1. In this ECG, there is significant ST elevation in leads 1 and AVL. There is significant ST depression and 1 and AVL as well as V4 and mostly V5 and V6. with ST depression in the anteroseptal leads and the inferior leads. This probably is a case of a lesion only in the left circumflex artery. Again, in this ECG, there is significant ST elevation in leads V2 to V6 as well as in leads 1 and ABL. But there is no elevation seen in lead V1. So it is possible that this patient has anatomically the septal branch first and then the diagonal first branch. That's why there is no significant elevation seen in lead. And thus this is a case of the left anterior descending artery occlusion producing extensive anterolateral walking. Now, in this ECG, there is significant ST depression seen in leads 1 ABL, 2, 3 ABF as well as the anterolateral leads with only ST elevation seen in lead ABR. So this only ST elevation in lead ABR with corresponding ST segment depression seen in all other leads is signifies left main coronary.
So my point is left main gives only these kind of findings or other findings also.
So left main occlusion should mostly give this kind of finding.
Only this kind of finding.
Also in V1
Yes.
My point is because left main, as we discussed previously, if left main is more, David's
Yes.
situation than the. So
This is a classical ECG representing left main
So for that when you have to look at the area over here.
and the corresponding
STD.
Yes.
But sometimes we say na global STD, the term global STD. What defines every STD changes mean T-wave inversion in all leads global STD.
Yes.
But we have to look at the area.
So how will you explain positive R wave in V1 and V2 in this ECG? Why it is there? Such a positive R wave.
It is still not enough. It is not infarcted. It is still not infarcted. It is ischemia only. At this stage.
ischemia can give rise to elevation in ABR.
Yes, because it has to be a left main equivalent situation. Maybe there is LED is tight or LC region is much more tighter than as compared to LED. That's why the R waves are preserved still. Because it is not infarcted. Q waves are not seen anywhere. Except some tiny Q waves are there in lead 1 and 2. Otherwise there are no significant Q waves. So patient is not yet infarcted.
સેકન્ડ ECG ઉપરની કોઈ કોમેન્ટ કરી શકે કે આને આપવું છે ઇન્ફાર્ક્શન છે એવું.
So if patient is having classical chest pain, then this is an imminent,
Yes, imminent infarct.
right?
This
Imminent
is
infarct.
ischemia, ongoing ischemia. Then it is left main equivalent. Now it depends on how tight is LN and how tight is LC. So maybe LN is only tight. But patient has no total occlusion of arteries at this stage.
Number one. Number two, which rhythm abnormality you will find in proximal LAD? કે આમાં અમુક જગ્યાએ નાની નાની હતી પણ તમે બોલ્યા નથી એટલે પૂછ્યું. બરાબર રોનક?
Yes.
Classical rhythm abnormality of proximal LAD block. A new onset DAS.
New onset left bundle branch.
Left? If your septum is not having blood supply from left side, it will produce left bundle branch or right bundle branch?
RBBP pattern.
RBBP. So new onset RBBP is always an issue. Most of the times proximal LAD or it can be B in other given context, but new onset RBBP તમારે બોલવું પડે ભલા માણસ બાકી ના ચાલે.
Yes.
આમાં છે કઈ?
RBBP.
Right? Then incomplete भी एक બે માં હતા એટલે તમે ના બોલ્યા એટલે મેં પૂછ્યું. ચલો.
In this ECG again, there is significant ST elevation in leads V1, V2, V3, V4, that is the anteroseptal leads, as well as leads V1 and AVN. So, and significant ST depression in the inferior leads. So, this is a lesion producing high lateral MI as well in the case of anterior wall MI. So, this is a lesion which is above T1. In this ECG, again, in this ECG there is ST elevation in leads V1 to V4 and not so significant ST elevation in leads V1 and AVL with corresponding ST depression in inferior leads. So this is a lesion which is above the central lead, that is above S1. In severe ECGs, if there is ST elevation in leads V1 and AVL, it may also lead to diagnosis of a lesion on a clinical diagnosis of an above T1 lesion.
In that first ECG, go to previous slides. The first ECG, suppose fortunately this patient is not in failure and blood pressure is acceptable, apart from your thrombolytics or opening of coronaries, which most important drug you will give first? Look at the pulse rate.
Yes, sir.
Suppose blood pressure is 140 by 90, patient is not having cardiac arrest, which is rare, and hase જ કદાચ પણ કદાચ નથી fortunately.
Yes, sir. A beta blocker.
IV beta blocker, yeah.
IV.
Can save your patient before you do proper treatment.
In this ECG, again, there is ST elevation in leads V2, V3, V4. There is no significant ST elevation in lead V1. We can take it as an ST elevation though. Leads V1 and area, there is no elevation.
V4 કરતા તો V1 માં વધારે લાગે છે મને. I may be wrong. તમે comment કરજો. હે ને? Product.
I'll say only V2, V3.
V2, V3 is significant. બાકી
બાકી
V1 questionable ને V4 માં તો કશું નથી લાગતું.
બાકી subjective.
subjective.
So this, if we do not consider the ST elevation in V1, this has to be a below S1 lesion. Now, again, I will be talking about a few leads, few ECGs taking inferior wall MI and anterior wall MI into discussion. In this ECG, again, there is significant ST elevation in lead 3, more than that in lead 2, along with V1, V2 discordance and some ST depression in leads V2 and V3. So this is a proximal RC occlusion producing inferior wall MI, that RDMI, with or without posterior wall MI. In this ECG again,
Same.
yes sir, it is a similar ECG but with ST elevation in lead 3, more than that in lead 2 with V1, V2 discordance. So this is a proximal RC occlusion. Now in this, again this is not a very classical ECG, but if we take the ST elevation in lead 2 more than that in lead 3, so this can be with, of course, as the right-sided leads are not showing any significant ST elevation, this can be taken as an L6 occlusion. Of course, we need to repeat the patient's ECG. In this ECG, the patient has significant ST elevation here in lead 2 more than that in lead 3, and also elevations are seen in the high lateral lead, that is lead V1 and leads V5 and V6. So this is a case of L6 occlusion producing inferior wall MI, lateral wall MI as well as of course posterior wall MI.
So such a huge depressor in AVR, it is highly unusual, but this is very significant. AVR માં જે depression છે ને.
તો 10 સ્લાઇડ બાકી છે 25 આવે છે.
Part 2 કરવું છે
Part 2 કરીએ.
કે ખાલી ECG જ બતાવવાના 5 મિનિટમાં બધી જશે?
Yes sir, these are the similar ECGs that I have already
એટલે
discussed.
રિવિઝન કરાવે છે ને તો તે કરાવી દે વાંધો નહીં.
So at the end I have discussed a few ECGs along with coronary findings of recent patients.
Go one step back.
This is not a case of a myocardial infarction. This patient already has developed few waves, and there is prominent ST elevation with T-wave inversion. So this is a case of old myocardial infarction with LV aneurysm morphology. These ECGs, as I already discussed, localization of MI in case of inferior as well as anterior leads. So this is an ECG of a patient, a recent ECG, a 73-year-old male, known case of hypertension, chronic smoker. He presented with chest pain since 1 hour. There is significant ST elevation here seen in lead AVR, along with ST depression seen in all other leads, that is the inferior as well as the anterolateral leads. On angiogram, the patient had triple vessel disease and he was advised coronary artery bypass surgery.
You should show the angiogram as well.
So angiogram.
Out.
Now, this was a ECG of a 64-year-old female. She presented with chest pain since 2 days.
So ECG માં differentiating points શું છે triple vessel disease and LMC that you have to discuss.
Yes, sir. Actually, on ECG,
છે બે ત્રણ point છે કે
sir, I'll go through those points.
something favors this thing, something favors this thing, which is not always 100%.
That is my homework. I will read about.
Okay, chalo good.
This is a case of a 64-year-old female. She presented with chest pain since 2 days and breathlessness since 1 day. Actually, this ECG is post PCI for the patient. There is significant ST depression seen in the lateral leads. On presentation, her ECG had ST elevation in lead 2 more than that in lead 3. Her 2D echocardiography also showed inferior and posterior wall hypokinesia. So this patient had an LCA occlusion. She was primary PCI was done for the same, as well as on the angiogram the same vessel, that is the left circumflex, was dominant for. Now this is an ECG of a 37-year-old male. He presented with chest pain since 1 hour. There is significant ST elevation in leads V2, V3, V4, V5, as well as that in leads 1 and ABL. There is not so much ST elevation in lead V1. However, on angiogram, the patient had a very proximal LED lesion and it was stented with 1 drug replacement.
So LMC ને LED માં બંનેમાં હતું lesion.
Sir,
And
there was only
LED ઓસ્ટિયમ હતું. LED ઓસ્ટિયમ હતું એટલે મીન્સ LED માંથી જગ્યા નથી. LMC એ 2 LED કરવું.
તો મતલબ LED માં ક્યાં સુધી તમે સ્ટેન્ડ જવા દીધું, કેટલા મિલીમીટર?
LED માં ઓલમોસ્ટ આને 40 નો સ્ટેન્ડ યુઝ કર્યો છે. હા, સો ઇટ વિલ બી 30 પ્રોક્સિમલ 30 ઇન
Approximately 30 અને LMCA માં બી એ સ્ટેન્ડ છે. ચાલો રિસ્કી નહીં યાર.
રિસ્કી પણ સર ઓપ્શન ના હોય ને, કેમ કે તમે ડાયરેક્ટ પ્લાકમાંથી કરો સ્ટેન્ડ થ્રોમ્બોસિસ થઈ જાય વિધિન 24 hours.
ભગવાન भी क्या क्या कराता है यार.
This is a 51-year-old male. He presented with chest pain, classical history of chest pain with 2 hours. In this ECG, there is ST elevation in lead AVR along with ST depression in all the other leads. So, as per the ECG, it looks like an LMCA occlusion, but on the angiogram, the patient only had a single vessel disease, a block, an occlusion in the LCH, and it was stented with 1 drug replacement.
એટલે આમાં પેલું AVR માં સિગ્નિફિકન્ટ છે કે ગણી શકાય?
1 મિનિટ 1
એટલે આ ECG પરથી બહુ કંઈ કોમેન્ટ
તો સાહેબ પેલી ફૂટપટ્ટી મૂકીને જુઓ ને એક્ઝેક્ટ તો જ ખ્યાલ આવે.
અઘરું પડે એવું છે.
અને આ જે સ્પીકર છે ને એમનો ST સેગમેન્ટનો એલિવેશન બહુ સેન્સિટિવ છે એટલે બધી એલિવેશન છે.
રોનકભાઈ તમારી બી કોમેન્ટ.
એસી એલિવેશન છે પણ એટલું સિગ્નિફિકન્ટ નથી લાગતું. મેબી 0.5 મિલીમીટર જેવું જ લાગે છે.
તો આમાં છે ને લાઈન બી 0.5 મિલીમીટરની તો હોય સારી એટલે અંદર કન્ફ્યુઝન
અઘરું છે.